Good morning, everyone. I am really happy to be here. I'm stepping in for Dr. Garen Stone this morning, and it's my pleasure to introduce our guest. So welcome to Professor Edgar Mulogo. He is an associate professor and the chair of the Department of Community Health at Mbarara University of Science and Technology in Uganda. He's a public health specialist. He has a particular interest in health system management and research. His work has focused on equity in access to healthcare across rural communities. He has a deep experience in working with the Uganda Ministry of Health, as well as many international partners. And he's an author on over 40 research publications. From 2013 until this year, our global medicine program has had the real privilege of working together with Prof. Mulogo and his department on a community health program in rural Uganda. In partnership with the Bugoye Health Center and local leadership, Prof. Mulogo has co-directed our efforts to support village health workers across the Bugoye sub-county to meet health needs of their communities. We're really delighted today to have him join us to discuss the program, as well as his leadership within the broader community health efforts in Uganda. So welcome very much to him. I'm going to pass the microphone over for his opening comments. Thank you, Prof.
Thank you, Dr. Louise. Good morning, everybody on that end. I feel really honored to make a presentation this morning during the grand round. And the presentation will focus quite a bit on community health workers in Uganda, because we've spent quite a number of years working in this area. I work out of a university in southwestern Uganda. It is called Mbarara University of Science and Technology. And one of our key mandates as academics at this university, apart from teaching, apart from research, is community engagement. And it is through that mandate that we have engaged in communities in this region and have done quite a bit of work among the communities through community health workers. So this afternoon, I'll share, morning on your end, I'll share quite a bit about what our program has done through the community health workers. But before I get into that work, I would like to give you an overview of our setup in Uganda as far as healthcare delivery is concerned, so that we can better visualize the work of the community health workers. So our presentation outline will include Uganda's location and the demographics, the levels of healthcare in Uganda, the community health worker structure and roles in Uganda. I also highlight an example of the community health worker program that we have been implementing, and I'll give an overview of the role of community health workers as far as the COVID-19 pandemic is concerned. Next slide, please. So Uganda is located in the eastern part of Africa, and in a region broadly known as the Great Lakes region, because of the Lake Victoria around there, with the Democratic Republic of Congo to the west, Kenya to the east, Rwanda, Tanzania to the southwest, Sudan to the north. Yes, and so the capital from where I am is about 300 kilometers away, say about 4 hours drive. So we are quite some distance from the capital. Next slide, please. With regards to the demographics, our population is slightly over 40 million now, predominantly female. But the key thing in the demographics that we need to look at is that we have a huge young population. From the slide, you can clearly see that the children who are below 18 years constitute about 53% of the population, slightly over half of the population. And so this, we know quite well from demography that this kind of population are mainly dependents. Next slide, please. So talking about the way the healthcare system is organized in Uganda is that we have tertiary, secondary, primary, community, and of course the household level. In the tertiary level, at the tertiary level, we have the national referral hospitals. Currently, we have mainly 2 national referral hospitals, and from the map I earlier indicated, these national referral hospitals are located around in the central region of the country. That means we are about 4 hours drive away from the national referral hospitals. We then have at the secondary level regional referral hospitals, the teaching hospital that is next to this university, regional. We also have what we call general hospitals. These general hospitals were formerly known as district hospitals, but their mandate has increased, and so now they are classified more as general hospitals and may serve a couple of districts instead of a single district. At the primary care level, we have the district health services. And within the district health services, we have a district health office that is responsible for oversight of the services within the district. And within the district or the primary care services, we have a hierarchy of health centers from Health Center 4 through to Health Center 3 and Health Center 2. Health Center 2s are placed at the community level, but they are more of within the primary, the district primary care services. So at the community level, we have what we call village health teams. These village health teams are what represents what is known in other areas, in other countries, as the community, the groupings of community health workers. So in Uganda, we refer to them as village health teams, and I'll describe them in quite a bit in the following slides. Then we have the whole households. So this slide here just depicts what is important from this slide is that at each of these levels, there is a catchment population. So when we are talking about the village health teams, the catchment population they are responsible for is about 1,000 people. When we are talking about the level 2 health center, it has a catchment of 5,000 people. When we talk of the health center 3, it is 20,000. The district hospitals typically would have a catchment of 500,000. The regional referral hospital, like the one we have here, catchment of 2 to 3 million. And the national referrals, of course, have the national catchment. Next slide, please. So the healthcare system is constituted by both a public sector and a private sector. Next slide, please. All the public facilities are run out of the Ministry of Health. So the government-owned facilities are a responsibility of the Ministry of Health of Uganda, and those within the public sector. But again, within the public sector, we have other kinds of health services. For example, in the education sector, we have the university teaching hospitals, and these also provide service. They have staff, they have specialists, and they also provide service within the public sector. Of course, then we have within the military, there are also health services within the policing, the prisons. They all have health services that are still within the public domain. Next slide, please. In the private sector, we have three categories of providers. We have the private not-for-profit providers, and these mainly provide services at the cost of the service. And they are mainly, the ownership is mainly by faith-based organizations and non-government organizations. We then have the typical private health practitioners, and these provide healthcare services on a purely private basis. So the expectation is that when you seek care from them, they get a profit from this healthcare that they are serving, providing to run their health services. The final category which we have among the private providers is those we call the traditional and complementary medicine practitioners. And those have a role to play in provision of services particularly among rural communities. Next slide, please. So clearly from the distribution of health facilities in the country, the government-owned facilities constitute the majority of the healthcare that is provided, but it is also notable that the private sector also provides quite a bit of services. The private for-profit or the private health providers provide about a third of the services, and the private not-for-profit provide 15% of the services. Next slide, please. So this slide just shows us a regional distribution of the health facilities. As expected, the central region where the capital is found has the majority of health facilities. Some regions have quite lower numbers of health facilities, and this of course creates disparities in access to health services. Next slide, please. Which brings us to the community health workers, who we could clearly see in the health pyramid that I showed. So the community health worker program in Uganda was initiated in about 2001. And the idea was basically to strengthen the delivery of healthcare services at a household level. So these community health workers that we refer to as village health teams in Uganda have a mandate, of course, to promote healthy practices at the community level, also to advocate for increased community uptake of prevention interventions for malaria, for communicable diseases and non-communicable diseases. So, but however, in 2010, a clinical or treatment platform was introduced to their mandate. And this was the integrated community case management, under which the village health teams were trained to provide treatment to 3 conditions in under 5 children. These are malaria, diarrhea, and pneumonia. So this was introduced in 2010, and it is what, in addition to health promotion and health education, a number of VHTs all over the country provide this treatment. In addition, one of the key issues that for introduction of the village health teams was also to establish a household health information system, and which the community health workers of VHTs are responsible for. Next slide, please. So the village health team structure, one, and importantly, is a non-political implementing health structure. It is, as we have mentioned before, responsible for the health of community members at the household level. Within each village, we have on average 4 to 5 VHTs or village health team members who are selected by a popular vote within each of the villages. So this, given that our villages may have around 150 households, each of the VHTs is responsible for 25 to 30 households. Next slide, please. So in order to be voted in, so to speak, as a VHT, you would need to meet a certain eligibility criteria. Some of the values they expect of you are: you need to be exemplary, honest, and trustworthy, and respected in the village. Critically, you need to be willing to serve as a volunteer. Of course, they have to be residents of the village and should be available to perform the tasks as assigned for VHTs. They should also, importantly, be interested in health and development matters, be good mobilizers and communicators, and be able to read and write at least in the local language, and are generally above 18 years. Next slide, please. So their roles essentially revolve around mobilization of communities for use of health services, health promotion and education, We have talked about the community-based case management of childhood illnesses. They are responsible for the community information management system. In some of the areas, they are responsible for following up mothers before, during pregnancy, and after pregnancy. Also follow up of people who have been discharged from the primary care facilities. They're also responsible for distribution of medical commodities such as mosquito nets. They're also responsible for disease surveillance, which has gained quite a bit of prominence following the COVID-19 pandemic. Next slide, please. So additional, these are have been mainly assigned to them by implementing partners who are outside government in the various areas where they operate. So their profile of activities has increased to neglected tropical diseases, HIV/AIDS, tuberculosis, reproductive health, immunization, nutrition, and sanitation. Next slide, please. Which brings us to the program that we have been implementing. So the program area is in southwestern Uganda, and it is right next to the border with the Democratic Republic of Congo. It is an area that has a difficult terrain, mainly hilly country, because it has a range of mountains right next to it. And the program is run out of a health center level 3 known as Bogoye Health Center 3. Next slide, please. So the aim of the program that commenced implementation in about 2013 was, of course, to improve the health of the local communities, strengthen the local health system within the district, and of course, innovate in community-based initiatives. The main focus of the program was the integrated community case management service that was provided through the village health teams. Next slide. So the program is implemented in a sub-county that has 5 parishes with a total of 35 villages and about 9,000 households. A catchment population of about 50,000, and has 8 healthcare primary care facilities, 2 of which are health center level 3 and 6 of which are health center level 2. The program engages about 133 village health team members. Next slide. So the key highlights from the program that we have implemented since 2013 within the 35 villages is that the community health workers or village health team members that we have been engaging with have had visits about 46,000 child visits for the treatment of malaria, diarrhea, and pneumonia. So the encounters for malaria have been about 15,000. The encounters for pneumonia have been 22,000, quite prominent now. The ones for women's related health, 4,000, and pregnancies identified at about 300. The community health workers also, of course, follow up these women, as we have noted, after delivery, and so they have been engaged in about 1,000 postnatal visits. What we pride our program for is that throughout this entire time of implementation, our community health workers have not lacked the vital meds that are needed to treat the children under 5, and this is one thing we are quite proud of and grateful for the support that we have received from all the partners. Next slide, please. We can clearly see that from 2013, the encounters have increased. We should note that we started off in 5 villages, grew in 2016 to 8 villages, and grew to 22 villages in 2018. So the upshot in numbers that we see in 2019 clearly was because we had brought on board more villages than initially we had. Next slide, please. On average, each of the community health workers sees about 10 to 15 children within a month. Of course, there are some outliers. In some cases, we have had villages where the turn up for treatment at particular VHTs has been quite high because the service probably was not present in some of the neighboring villages. So we had spillovers from neighboring villages from out of the sub-county that were coming over to access the services. Next slide, please. So the outcomes of our program is that the coverage of ICCM improved from about 23 to 63% in the sub-county. The program, as I have said, is in 22 villages. In the other, because I mentioned that there are a total of 35 villages in the sub-county, so that meant that we were not providing ICCM directly in 13 of the villages within the sub-county. But under our program, we were supporting 26 health workers in the 13 villages that are providing the government-supported ICCM. And because of various issues within the health system, it's quite apparent that the government-supported community health workers from time to time experience different challenges with regards to meds, with regards to diagnostic kits and those kind of things. So our program has supported them in provision of meds where there is a short supply, and of course in quality assurance through refresher trainings and supervision. The outcomes that we have seen from the program that we have, of course, it has increased accessibility to the children under 5 within the sub-county, and this has directly impacted on decreasing the attendance of under 5 children at the health facilities within the catchment. We clearly see that now most of the people presenting at the health facilities with malaria are those above 5 years. And this has greatly also decreased the load, the outpatient load, and reduced the pressure on medical commodities for these health facilities for treatment of these conditions that are being managed by the VHTs. Of course, during the conception of the community health worker program and the introduction of the treatment platform of ICCM, one of the key aims was to ensure that children, once they have these childhood illnesses, are able to access treatment within 24 hours, which was not happening when they had to go to health facilities. So as a result of the program, of course, we have seen an increasing number of under 5 children who have accessed treatment within 24 hours. And of course, this, if we know when they access treatment during this time, the health outcomes are better. Notably, of course, the health facility workers at Bugwe Health Center 3, because the continued engagement, their capacity has been built in the supervision of VHTs or community health workers, in the training of the community health workers. And this capacity actually is being used by the district to train and support community health workers in neighboring sub-counties. Next slide, please. Here we have the first group of VHTs that we trained in 2013 and who began their program, and we can see the kind of medical supply boxes that they have within their households to facilitate this treatment. Next slide, please. So what have the community health workers been doing during the COVID pandemic? Next slide, please. So one of the mandates we saw much earlier is that the VHTs are responsible for disease surveillance for a number of conditions within the community. So this function was strengthened with the emergence of COVID-19, mainly because the VHTs are proximal to the community, and also they are that link between the community and the formal healthcare system. So the community health workers, or VHTs as we call them, received training for COVID surveillance. In some areas, I can't say this has been across the country, but it has happened in certain areas. And in some of these areas, the VHTs, a village COVID-19 response team or task force has been formed at the village level. And through this task force, support is provided for the COVID response at the community level. So they have been involved in identification of suspected cases based on the government protocol, and notification of the district in case of a suspect. They do this mainly through a toll-free line that they can call. And of course, they communicate to the communities any health-related information with regard to COVID. Next slide, please. So this slide is not very clear, but this is the community triage protocol that is used by the VHTs and the district surveillance team with whom they are in contact. I believe that is the last slide. Thank you. Oh, okay. So the challenges related to the VHTs is that although in the eligibility criteria, we saw that anybody above 18 at the community level can be a VHT. Most of the VHTs in our program area and in other areas are elderly people. We have mainly on average people who are 40 and above. And because of this, it was considered that they could be vulnerable because of their age during the initial outbreak. And so this posed a challenge with getting them really to be part of the COVID response. The other key challenge, of course, was the limited availability of PPEs through our program and other programs which are supported by other implementing partners. The VHTs were provided with masks, were provided with sanitizer, but the sustenance of those supplies is still quite a bit of a challenge. A key challenge, of course, for them in implementing surveillance, particularly in doing home visits, is the fact that they are volunteers and probably have transport constraints. And because they engage in other productive activity for their households, time is also an issue. Next slide, I believe that's the last slide. Next slide. Thank you very much.
Thank you very much. That was.
Okay, thank you.
Yeah.
Yeah.
Sorry, go ahead.
Yes, thank you very much. I would welcome any clarifications, questions.
Yeah, thank you. I have lots of questions, and I know we have a couple coming in from the attendees too. Please go ahead and place your questions in the Q&A, and I will pose them. But Prof, I have a question. Let me start with the question around, and we have talked about this before, about volunteerism and paid health workers. And you mentioned it as potentially one of the challenges. And I'm curious where your thinking is and where the government of Uganda's thinking is now around payment of community health workers who do so, they work as a pride and a volunteerism, and they're elected by their communities. So there's a lot of community spirit, but also, especially as we ask them to do a variety of tasks, I'm curious on your thinking about payment for community health workers?
Well, the volunteerism aspect for community health workers is actually a big issue currently with the Ministry of the Health at the national level, because as I said, the program was initiated in 2001, that is like 2 decades ago, and they received basic training at the time to do health promotion, mainly prevention messages. But as the years have gone by, their profile of activities has increased. And you know, with the coming of different implementing partners, each of them comes with activities within a new health area, and everybody looks to the VHTs. It's been a challenge. The government over the past, let me say, 3 years has felt that this needs to change, that the VHTs cannot continue to volunteer, and that some form of remuneration should be found for them. With this in view, the government in 2019, they decided to go and benchmark on a program that is being run in Ethiopia, because they have a well-developed community health worker program. And in Ethiopia, they found a cadre of community health workers known as community health extension workers. So the view of government at that time is that they could introduce the same approach here, such that the community health extension workers were paid employees of government. However, it hit a major snag, and I think there was some initial piloting of the program in a couple of districts to see how it would work. But it hit a snag in that the government could only pay, say, month session to 2 community health workers per parish. A parish has about, on average, 6 to 12 villages. So there were arguments back and forth as to whether these people would be effective in delivering the aspects of the community health worker program that was ongoing in the country. So the idea was shelved for the time, and I think there were people who are much higher in authority who felt that with upcoming, I believe, elections and all these kind of things, it wouldn't sell well with the communities to see that their village health team members are withdrawn from service in preference for community health extension workers who have very limited coverage. So the whole idea was shelved. But the good thing about it is that the government has recognized that this volunteerism cannot go on, and these people need to be paid. The mechanism for compensation is still difficult because government, of course, is constrained by resources. If they are unable to give reasonable compensation to health workers who are formally employed, it also becomes a challenge now to support the community health workers at this level. But all I can say is that there is awareness that it is a big problem, and with the growing profile, as we said, of activities, something needs to be done. Yes.
Yeah, thank you so much. You mentioned in your last slide some of the challenges, including challenges around PPE. Could you give us some more update on how you have access to PPE for the village health teams, and also if they might be prioritized in vaccination campaigns, or how, what the challenges are there specifically related to COVID-19?
Excellent. So fortunately for us, with COVID-19, the government has given priority to health workers, and health workers have included the community health workers. So what has happened is that with the distribution of PPEs to the primary care facilities are mandated to supply PPEs to the community health workers, and this is what has happened. Of course, we have shortages here and there, but when they are available, for example, out of Bugoye Health Center 3, whenever they have sanitizer, whenever they have masks, these are provided to the community health workers. With regard to vaccination, the community health workers are also given priority, just like any other health worker. So the community health workers have actually received their vaccinations. So I'm glad about that.
Yeah, that's great to hear. My next question, you mentioned disparities and inequities, and community health workers can be a real support in trying to get access and bridge into the health system in communities that are historically marginalized. How do you see community health workers in that role, especially as it relates to rural communities there?
Thank you. So the community health workers initially were envisioned to stay within communities and probably get supervision from primary care facilities. But what is happening now is that the primary care facilities, because of course, we have to remember that the community health workers are volunteers. So, but innovative primary health care facilities have brought on board these community health workers at the health facility. So they at the health facility, they are mainly involved as triage agents for people who are coming in through the outpatient department. So this not only gives them recognition within the communities, but provides that critical link between the services that they are providing within the community and ensuring that for any referrals or for anybody who needs care, who has come through the community health worker system, is linked directly to the health facility through that agent who is based at the health facility. So this, I think, has improved, because when communities, normally you will hear complaints when people come into the health facility directly and not through a community health worker, they may spend a bit of waiting time and all these things. But if you have come through the community health worker system, you have somebody who is there, who is able to link you immediately to receive care without long waiting times or not seeing the clinician and that kind of thing. So I think this has reinforced, and this, I believe, is the way to go in that linkage between the community level and the community health workers and the primary care facilities.
Great, thanks. Okay, I'm turning to some questions from the audience. So Dr. Lynn Black was wondering how many of the village health team workers are women compared to men.
So in the guideline, the training guideline that the Ministry of Health has put out for selection and training of the community health workers, a third of the village health team has to be women, and they have to meet that quota. So if you have probably 5, then we know that maybe 2 should be women, at least 2 should be women. But currently, from the statistics that we have on village health, community health workers in Uganda, we have maybe about 150,000 community health workers. The distribution is about 59% are males and about 41% are female. So
Okay.
certainly the guideline has been followed, yes.
And do you think the guideline might move to 50-50?
Actually, in some villages, it is more of the females, maybe 60 and 40% men. So in some villages, it's completely reversed, yes.
Well, I would personally be loving to see a future of 50-50. Okay, I'll go to, okay, Howard Weinstein, Dr. Weinstein has been mentioning that in his conversations with Dr. Barnabas about the childhood cancer program there, that there's been quite a lot of abandonment of cancer care. And Dr. Weinstein is wondering if village health teams could help with this problem of staying engaged in care for cancer care.
We would all love the VHTs or the community health workers to be engaged in such conditions. But for me, I feel for the VHTs because different programs are cropping up every day, and we remember that we are working as volunteers. So it would be good, yes, but it would increase the workload. For these volunteers who also have to be engaged in productive activity for their households. And because in some of the villages, the VHTs actually are quite engaged in a lot. In the Bugoye program, they were engaged in ICCM, which is their mandate clearly, but they also engaged in HIV, in TB, case follow-up and these kind of things. They're engaged in reproductive health. Yes, they can play a role, but I think it would be putting too much on their plates in certain areas. Yes.
Yeah,
but if you
that's
had
very
the resources, if you had the resources to support them for the program, then they would. I'm more than certain that they would be able to cover that.
So on that question, within the framework of the Ministry of Health's systems, is it allowable for programs to pay community health workers if the resources exist, or does that create too much disruption to the overall system? So let's say there was a program for engagement in cancer care for children, then it seems like some community health workers would be paid and others wouldn't, and it might be what your perspective on that?
Hello, can you hear me?
Yeah, could you hear my question?
Yes, I got the gist of the question. Yes, so what a number of implementing partners have done is that they have found innovative ways of compensating the VHTs that do not breach the government policy. Because if you paid them directly and said this was compensation for working in this area, it would cause, as you said, it would cause a lot of disruption. Okay, because in some areas, some of the VHTs are not able to receive this compensation, and maybe the compensation is given to these VHTs in limited areas. So, but the innovative ways that implementing partners have found is that the VHTs are provided with a transport refund when they come to do their reporting. For instance, when they are bringing in the registers, like if you had them bringing information related to your program, then you could give them a transport refund that is allowable. When they come in for refresher trainings, they are given a compensation for transport and that kind of thing. So there are innovative ways of framing the compensation that does not go against the government policy, and this is what a number of people have done.
Okay, great, thanks. Okay, a question now from Bridget Burns. So her question is about community health workers providing informal mental health services to their community members as part of their work. So I think, and Bridget, please put in the chat if I'm getting it wrong, but rather than, Bridget is not proposing, oh, let's create a new mental health program, but she's asking about them already doing informal mental health services. And if you know how that impacts their relationships, how they're learning about psychiatric suffering of their community members. What's your experience with the village health worker teams and mental health?
Well, yes. Well, typically in our program area, we have not had a mental health program, but in a neighboring district, I know that the VHTs have been trained to identify patients with some form of mental illnesses like epilepsy. They have also been trained to offer some kind of counseling to mitigate the stigma associated with conditions such as epilepsy that are common in that neighboring district that I'm talking about, and then also, of course, providing referral support to patients with mental illness. With regard to providing some form of psychiatric care, no, to the best of my knowledge, I have not come across those kind of community health workers. Yes. So it's mainly identification, referral, and some sort of counseling support and awareness creation around the mental illnesses. That's the role that they are playing.
Mm-hmm. Interesting. You know, in my experience in Haiti, working with community health workers, they were originally hired for the HIV and TB programs, but we discovered that they became very much the person in the village that anyone would go to with any problem. And they were even described as doctors in the community. So they would see the person with mental health distress. They would see patients with first aid problems. Even though in our mind they had a very specific role, they actually took on a much larger role. So I think it's very interesting to think about what kinds of issues the village members are bringing to them. Let me ask another question about related to the COVID-19 pandemic. So, you know, obviously some of the countries that were listed as being the most prepared for global health emergencies have done the worst in terms of COVID-19 cases and deaths, including in the US. And I'm curious on your perspective of the community health in general and community health workers, but how you think community health and the investments in community health may or may not have contributed to Uganda's successes so far in the pandemic. And maybe you could comment on, you know, surveillance and other types of community health work activities, but also just those investments outside the big major hospitals.
Okay. So at the community level, when we had the COVID-19 pandemic outbreak in Uganda, is that one thing to note is that we have very well established community level structures. So just to give you an idea, within each village we have a committee, which includes a chairman who is like the village leader, and who has various committee members for women, for youth, for security, and so within this community, the committee, we have the community health workers appended. So what happened is that when we had the first few cases and people were being asked to report to health authorities, a number of people would run off to their home villages, to their areas. But these committees in each village were mandated to trace and report anybody. For example, I remember very well in April and March last year, these committees were mandated with tracing anybody who had been, one, out of the country, two, who had traveled from the center, from the capital city and all these urban areas. And they were quite engaged in this activity. You could not get into a village when you had been away for some time without being reported. So this was very key for surveillance and identification of suspects and tracing of contacts of the initial cases that we had. So because of this community health system, it enabled the country to mitigate this community transmission. And as we have seen in Uganda, the community transmission actually started much later during the pandemic. So that helped quite a bit. Two is that this structure is replicated at different levels within the country. So communication is facilitated right from the national level through the subnational district levels, the county level, the sub-county level, the parish level, up to the village level. And this, as I have mentioned, greatly helped in containing what could have really been huge transmission in the communities. Just remind me about the next aspect of your question.
I was asking, I think you're already kind of answering it, but maybe maybe to expand the question, you had talked about surveillance.
Yes.
So I think tracing, contact
Yes.
tracing and surveillance go together,
Yes.
but maybe,
Tracing, yes.
yeah, I was also
Yes.
curious if the surveillance is also related to training that village health teams have had related to Ebola virus disease or other potential outbreaks that you might be looking for, or if this was a brand new surveillance activity for them.
No, it's not brand new in that in this region, like particularly in the southwestern region, we have had outbreaks of Marburg, of Ebola, and of Rift Valley fever. So it has been quite critical for the district health systems to train the VHTs for surveillance for these conditions. So with the coming of COVID-19, of course, the area, this was not a new area, surveillance area for the VHTs. So their knowledge was just reinforced with regard specifically to surveillance of COVID-19, but it is part of their mandate really. They do surveillance of other conditions such as hepatitis B, rabies, polio. Yeah, so it's part of their brief really. So they just received training to reinforce them, which is related to COVID-19.
Thank you. I'll just give to the audience. Do you have any last question for Professor Mulogo? Please go ahead. And I have one more question. Community health workers have so much real world lived experience of the health challenges of the communities. And I'm wondering how we could help to elevate, amplify experience and their wishes, their voices within the health system. How do you think, is there already an active kind of place for them at the policy table in Uganda? How can we, on the global level, help to support that?
At the Ministry of Health, we have a unit that is responsible for the VHT program in Uganda. The unit is under Directorate of Community Health and Clinical Services. But as of, let me see, from 2019, this unit within the Ministry of Health has had challenges with funding. They have not been supported within the Ministry of Health to do a lot of work around the VHT program. What has happened is that we have big agencies like UNICEF who have realized the critical role of the VHTs and actually have been engaged in supporting the programs, such as the training of trainers for the VHTs at the district levels. This has been supported mainly by agencies such as UNICEF, Save the Children. And in my thinking, although a lot of implementing partners, the government, for example, when they are doing the recent bed net distribution and all these things, are really using the VHTs to provide some of these services. But they are not being given the due attention in terms of resources from the central government, because the districts also do not have enough, because they mainly receive, although decentralized, receive resources from the central government. So at a global level, my feeling, and just like the program that we have had in Bugoye, is really around providing evidence about the work that the VHTs are doing and sharing this evidence in things like policy briefs, and these could be an advocacy tool for maybe the enhancement of resources from the government or resources from other partners globally who are willing to contribute. So for us as an academic institution here who have been working together with them, yes, we need to provide that scientific evidence on these outcomes that we are seeing through the community health worker program to the ministry, and hope that through that we are really advocating for at that level for the VHTs and for all the work they are doing. I think that is the best we can do at the moment. But on the government end, this resources as funding in particular is still a challenge. Yes.
Well, we're at time. Our time is up, but that was a fabulous presentation and summary of all the work that you and your teams have done, and it was really a privilege. I feel like even though there's many people on the line, I feel like we were just having a little chat. So I very much
thank you.
I very much appreciate you sharing so much information with us, and thanks everyone for joining us, and wish you a good evening in Uganda and good day to the rest of you all.